Hi, I'm Dave Little, CEO of SDF, and I'll be chairing today's webinar. The webinar will run to 2:15 to allow sufficient time for questions. The Scottish Drugs Forum is hosting this webinar with the Drug Desk Taskforce. This is the first of two webinars looking at benzodiazepines. The first session will focus on trends in the supply and use of benzodiazepines in Scotland. And next Friday, the webinar will focus on how services might best respond to dependent use of non-prescribed benzodiazepines and current and emerging practice in relation to prescribing. This issue is of crucial importance to Scotland, particularly as non-prescribed benzodiazepines has become such a significant and growing feature of Scotland's tragically high fatal overdose figures. Polydrug use has always been a feature of our drug overdose deaths, but the role benzodiazepines plays in these deaths has been increasing. In 2008, for example, there were 179 deaths where benzodiazepines were implicated out of a total of 574 deaths, 26% of the total. By 2008, benzodiazepines were implicated in 782 of the 1,187 deaths, 67% of the total. So the scale of the challenges is huge. Today we'll hear from Andrew Macaulay, Senior Research Fellow, Glasgow Caledonian University and Principal Scientist at Public Health Scotland. Harriet Bloomfield, Researcher at Glasgow Caledonian University. Joe McManus, Health Improvement Lead, Drug Prevention and Harm Reduction, NHS, Greater Glasgow and Clyde. And Craig Mackenzie, Principal Investigator in Forensic Chemistry, University of Dundee. We'll hear from each speaker in turn, and then we'll have a question and answer session at the end. Attendees can submit questions, and we encourage you to do so throughout the webinar. The questions appear in the tabs on the control panel, which should be on the right-hand side of your screen. Austin Smith, SDF's Policy Officer, will join us for the discussion session at the end of the presentations, where he'll summarize the questions, and I will put them to the panel. Questions and comments will also be shared with the Drug Desk Taskforce for review after this webinar. So let's get started, and I'll hand over now to our first presenter, Andrew Macaulay. Over to you, Andrew.
Thanks, Dave, and afternoon, everyone. I'm delighted to be asked to present at today's seminar. So really, first of all, I'm going to set the scene for a lot of today's talks, building on some of the statistics that Dave has just presented to you there. And we've titled this The Rise and Rise of Benzodiazepines and Scottish Drug-Related Deaths, because we thought that healthily captured exactly what's been happening over the last decade or so. Next slide, please. So benzodiazepines are amongst the most widely prescribed psychotropic drugs in the world. And over the last 30 years, Scotland has had a very strong relationship with the use and misuse of benzodiazepines, from temazepam, diazepam and triazolam in the mid-1980s through to the new novel psychoactive substances such as atizolam and phenazepam in the 2010s. Next slide, please. And this is within an environment where benzodiazepine prescribing in primary care has steadily reduced over the last 20 years in Scotland, particularly over the last decade. In part, these reductions are due to concerns about benzodiazepine dependence and inappropriate prescribing, and have been achieved by general practitioners and prescribing support teams working to review and reduce benzodiazepine and Z-hypnotic prescribing where appropriate. And increasingly, the illicit market supply of benzodiazepines has been replaced from diverted prescriptions to the availability of benzodiazepines on the street that are non-prescribed. Next slide, please. Now, building on what Dave said in his intro, in contrast to the decrease in benzodiazepine prescribing over the last decade, benzodiazepine-related mortality has been increasing, especially in recent years. Benzos have always been heavily present in toxicology and Scottish drug-related deaths, but not always deemed to be contributing to the cause of death. This trend has changed markedly in recent years. In 2018, benzodiazepines were implicated in or potentially contributed to 792 deaths, which was 67% of the overall total. And street benzodiazepines such as atizolam were prevalent in most of these deaths, 675 of them, or 57% of the total year's drug-related deaths, with prescribable benzodiazepines such as diazepam in a minority of cases, around 20%. Next slide, please. And you can really see, sorry if you go back a slide, and you can really see that although benzodiazepines have been prevalent in Scottish drug-related death toxicology for a number of years, it's really since 2015 that their presence, the proportion of their presence has really increased hugely, well above 50% to now around 2/3 of drug-related deaths in Scotland. Next slide, please. And most of this recent rise in the benzodiazepine involvement in drug-related deaths is driven by the new or novel benzodiazepines, or the street benzos, as they're often referred to, the non-prescribable drugs. And it's particularly atizolam. If you look at this graph here, for those that are not able to see the legend on the side, the very vertical blue line, which is very stark in the graph, is the atizolam line, and you can see very synonymous with that rise since 2015 has been the rise in atizolam involvement in drug-related deaths. So put another way, almost 1 in every 2 drug-related deaths in Scotland in 2018 involved atizolam, which is quite remarkable given it was a fairly non-existent drug within the field back in 2013-14. But interestingly, if you look at the graph, diazepam-related deaths have also been increasing in recent years despite the controls and prescribing. And you can see at a lower level some of the other drugs that we had been concerned with in the past, such as phenazepam before it was controlled, and more recently drugs like alprazolam, also featuring some increases in trends. Next slide, please. Now, one of the things that's quite remarkable about that Scottish graph in terms of benzodiazepine involvement in drug-related deaths is it very much mirrors the graph which has been well publicised in relation to opioid-related deaths in the USA. They also have an almost vertical-like increase in the involvement of synthetic opioids in drug-related deaths in the USA. And again, one of the hypotheses has been that the drive of synthetic opioid use in the USA is partly due to controls on prescribing of opioids in the USA. Similarly in Scotland, at least partly one of the rise in street benzodiazepine use in Scotland has been driven by more tighter controls on prescribed benzodiazepines. Next slide, please. Why do street benzos matter? Well, they obviously matter because they're impacting on mortality rates substantially in Scotland. But we look at the specific drugs themselves. There are a few key issues it's important to draw out. First of all, the increased polydrug toxicity, and we know in Scotland that people rarely die from a consumption of a single drug, so they're increasing the potential risk of overdose. Secondly, when compared to traditional benzodiazepines, street benzos are very different drugs. They're often stronger. Not all of them stronger, and we'll come to that point in a minute, but they are often stronger and contain a different makeup. They have a different half-life, so their effects don't last as long, so people often feel compelled to redose more frequently. And obviously, traditional benzodiazepines are prescribed, so there's a degree of quality assurance there that we don't have with street benzodiazepines. And thirdly, we call this false advertising, or the consumption roulette that users face on a day-to-day basis, because street benzodiazepines often are made to look, smell and taste like something very different to what they actually contain. And again, we'll come to that point in a second. Next slide, please. So back to that point about do they increase overdose risk and polydrug toxicity. Well, this is the same graph you've seen a few slides ago, but this is just to highlight that atizolam in particular is very rarely taken in isolation. Of all the drug-related deaths where atizolam was involved, only 7 of them, in only 7 of those deaths, atizolam was the only drug involved, so less than 1%. Next slide, please. Now, one of the labels that's been attributed to atizolam is that it is more lethal than diazepam. It's a much stronger drug. So myself and Suzanne Nielsen, a colleague from Australia, pharmacology, who also works in the addictions field. We did a rapid review of the evidence on atazolam to try and substantiate some of these labels that had been attached to it. So first of all, in terms of its shorter half-life, absolutely, atazolam has comparably against other benzodiazepines amongst the shortest half-lives. So that very much fits in with the anecdotal reports of people redosing frequently on it. Certainly in laboratory studies with mice and rats, atazolam is less lethal than diazepam, but we must remember as an anxiolytic, atazolam is considered to be 5 to 10 times more potent than diazepam. And that very much fits in with the anecdotal reports we get of people losing long periods of time after consumption of atazolam, very dazed recollection of what they've done when they've been consuming these drugs. But very importantly, this rapid review showed us that in terms of atazolam, no studies had examined effects on cognitive function outside of a therapeutic dose range. They were either done in laboratories with mice and rats, or they were done with prescribed populations in countries where atazolam is available on prescription, such as India and Japan. In Scotland, it's very much a street drug produced in amateur chemistry labs with people taking mega doses, and there is no literature available at the moment on the effects of atazolam when it's consumed in this way. Next slide, please. Now, in terms of this consumption roulette, I think Craig may go into more detail on this later, but this is actually quite an old slide now. This is back from 2016, but this very much captures what we've seen in the years since. And this highlights how the street benzo market operates. These drugs very much marketed to look in a very certain way. These are the yellows of the time. But when broken down, this drug was found to contain diclazepam, diazepam, atazolam, and a synthetic opiate. A real fairly dangerous cocktail of drugs in this one tablet, and it's not unusual for us to see atazolam tablets and seizure data containing a multitude of different substances. Next slide, please. And this is just some more reporting about atazolam that we've seen recently in the press, and this image on the right captures some of the different varieties of atazolam that have been seized over the years. Interestingly, you can see this headline saying that atazolam is 10 times more deadly, and that was partly one of the reasons we wanted to do the systematic review, to quantify some of these kind of urban myths around it. Next slide, please. Now, one of the other interesting aspects of the Scottish benzodiazepine market in recent years is that it's very much moved from an import market to one that is increasingly domestically produced. These stories or headlines were very much related to a high-profile bust the police did in Paisley a couple of years ago of a pill pressing factory and an industrial unit there that was able to generate huge volumes of pills there. And this was some of the first evidence we had of the sheer scale of the domestic production atazolam market there. Next slide. And the police were happy to share this picture with us. This is inside the lab that was busted, and you can see almost the kind of chaotic nature of the laboratory, or the kind of pill pressing area where the atazolam tablets are pressed. And you can see in this washing basket down to the left in the pink, you can see the volume of pills that had already been pressed that have been deposited there. But the kind of waste and detritus of all the different dust around that is generated there, these are not safe, quality controlled environments where drugs are being made. You can see the sheer volumes that they're generating. Next slide, please. And we like to include this slide as well. Just it's usually helpful to an international audience. And this could be an international audience today because it's going online. But this was also recovered at the scene. This is flumazenil, which is the benzodiazepine antidote. So although not a lot of quality control and quality assurance in terms of the pressing of the pills, there was some health and safety in place should the people working in this factory get into any danger. Next slide, please. So just to summarise, there is high demand for benzodiazepines among people who use drugs in Scotland, certainly alongside other drugs, and the high demand for benzodiazepines has spanned nearly 3 decades or more. But certainly in the last decade, we've seen a shift from the diversion of prescribable benzodiazepines to a more street-based illicit market of benzodiazepines, and this has certainly increased the risk environment for those consuming benzodiazepines alongside other drugs. These drugs are increasingly domestically produced or pressed, which means they're less affected by international markets, and we've certainly seen over the last 6 months of the pandemic that the availability of street-based benzodiazepines has not changed at all in Scotland. They're as available and affordable as they have ever been. And finally, just to touch lightly on policy and practice responses, although that's not what this presentation is about, it's more about setting the scene. But I would like to take the opportunity to highlight that policy and practice responses require flexibility and innovation. The status quo for benzodiazepine interventions cannot be allowed to continue in the face of the harms that are presented. Next slide, please. That's me. Thanks, Dave.
That's great. Thanks. I did get in at the right time there. Thanks very much, Andy, for that excellent introduction of the issues, and we'll come back, I think, to your final point in the questions. I'm pretty sure of that. Before we come to our next speaker, I just wanted to highlight the fact we've got now 515 people on the webinar today. So I think that highlights the importance of this issue for the sector. I'd now like to ask our second speaker, Harriet Bloomfield, to present. Thanks, Harriet.
Hi, thank you. Hi, my name's Harriet Bloomfield. I am a researcher in the field of substance use. Thank you, Andy, for setting the scene. I'm not going to touch more on this because I'll probably run out of time. Today I'm going to present some findings from a recent qualitative study that I was involved with whilst working as a research assistant at the Drug Research Network Scotland within the University of Stirling. So next slide, please. So to give an overview of the project, a collaborative multidisciplinary group convened by the DRNS was formed. And this consists of addiction specialists, other healthcare providers, researchers within academia, and individuals with lived experience. So we wanted to get a better idea of benzo usage and personal perceptions from those with lived experience. So this study was launched. We utilised some links with the Turning Point and the Simon community, who agreed to put up a participant recruitment poster within their service and encouraged people who use benzos or have experience of benzos to get involved. So this brings me to the next slide, which will talk more a bit about the study methods. We had originally aimed to host a few focus groups across Scotland with people with lived experience. However, due to COVID-19 sweeping in, we were restricted to telephone interviews only. So we managed to conduct 12 telephone interviews throughout June and July. Participants consisted of 7 males and 5 females, aged 31 to 51. Each interview lasted around 30 minutes to an hour in length, and participants received a £20 Love to Shop voucher, which was sent by text or in the post. So the following themes emerged, which I'll be discussing throughout this presentation: availability, motivations for use, risk behaviours, the short and long-term effects of benzo use, opinions and experience of a benzo detox, and finally, opinions and experiences of psychosocial support. Next slide, please. So this brings me on to the first theme, which is availability. So 3 participants had said they initially acquired their benzos via a prescription from their friends and family. This is before they sourced them illicitly and started using street benzos. Almost half the people I spoke to had received their own benzo prescription, and of which 2 of these had actually sold their own prescription to friends. Every participant I spoke to said that there was an abundant supply of benzos on the streets. Most participants reported using drugs sold as Valium, in particular 5mg blue tablets and the 10mg white tablets. But the key theme here was that they could be bought really cheaply. Prices range from around £1 per pill if they were bought in small quantities, but one participant once spoke of buying 500 blue Valium for £80, so that's 16 pence per pill. A couple of participants spoke about buying large quantities in bulk via dealers or online, taking half for themselves and then selling the other half. So one male in Lothian said, the more you buy, the cheaper they get. So you tend to buy a lot more than what you need, but you're just getting them so much cheaper. It's a vicious circle, because when you start running out of money, then you start selling them and become part of that problem. So moving on to the next slide, we're just going to discuss motivations for use. Responses varied. Whilst a couple of participants spoke about using benzos as a confidence boost and to help with productivity and motivation, this often developed into using them later on in life to combat anxiety issues. 3 participants used them mainly for insomnia. 5 participants spoke of high levels of anxiety and not being able to function without the presence of benzos. However, the most dominant theme amongst 11 participants was deep-rooted trauma. So this ranged from a family history of addictions, domestic violence, loss of life and tragedy, eating disorders and personality disorders. So all of these participants said that benzos were just the easiest, cheapest option to mask their negative emotions almost instantly. This brings me to the next theme in the next slide of risk behaviours. So all 12 participants that I spoke to acknowledged the risk of using street benzos, in particular acknowledging the fact that there might be varying levels of purity and the presence of unknown contents and coming across counterfeits. So 2 participants who I spoke to, very both current users, current heavy users in their words, spoke about losing friends on a weekly basis due to benzo use. It was quite sad. There was a sense of desperation in their voices, as they said they can't live without them because they need it to mask mental health issues, but every time they do consume them, and I quote, they are dicing with death. Around half the participants I spoke to said they'd previously taken excessive amounts. So one guy said he had once taken up to 100 5-milligram street Valium in just one day. He claimed because they are so easy to consume, just to swallow a handful of pills, it is easy to just take excessive amounts. Other risk factors which were mentioned were the normalization of benzos and taking them alongside other drugs, and in particular other depressant drugs like alcohol. Moving on to the next slide, and the 4th theme is the negative effects of benzos. So some language which appeared in over half of the people that I interviewed was the words invincible and invisible. So this confidence boost often led to criminal activity, such as stealing, such as breaking things and vandalizing. However, more often than not, participants said that they couldn't remember the tail end of these events. A couple of male participants I spoke to said they'd woken up in the cells before following a benzo bender, being charged for all sorts of things that they couldn't remember. One person I spoke to said he was currently on trial for attempted murder, which was all due to benzo use. Memory loss was spoken about by every participant. Some accounts were more severe than others. Others spoke about uncontrollable aggression, rebound anxiety, dependency, and withdrawal. So the next slide, please. The final 2 questions of the interview were focused on interventions and support which might help a person dependent on benzos to reduce their use or become abstinent. So first, I asked about opinions and views and experience about benzo detox or tapering plans. All 12 participants agreed on the fact that to stop benzos abruptly was just not an option. 2 individuals I spoke to said that they'd actually experienced aggressive seizures after halting use suddenly. There were mixed opinions from participants regarding if a detox should be prescribed or non-prescribed, but that's mainly boiled down to having a good relationship with your GP or addiction worker. One participant, who was a previous benzo user, was very passionate and very against the idea of prescribing benzos to a street benzo dependent person. So he said that it might add complications because the individual will not be used to pharmaceutical grade benzos, which may contain more of the active ingredient than street benzos or less. So it would just add complications as the body just isn't used to pharmaceutical grade benzos. Finally, on to the next slide. Participants were asked about their experience and opinions about psychosocial interventions. Half of the participants I spoke to, previous and current benzo users, were enrolled in smart recovery meetings. So they spoke very highly of this intervention, and it was great because they were in a mixed group of people with varying addictions, so not all benzo dependent, and they could see where they once were in their stage of recovery, and they could see where they aim to be. So it was a motivation for everyone involved, and the participants I spoke to said it was really good feeling knowing that they were supporting others throughout their struggles of addiction. However, I did speak to two people who really disliked the idea of smart recovery groups. They said that they didn't like speaking to people who they knew already. One female participant said, though, that she could potentially entertain the idea of attending a group in a different city where she didn't know anyone. But the general feeling from participants was that it was vital to have a strong bond with either a GP, a specialist addiction worker from third sector service, or peers from group sessions, or a community psychiatric nurse. Without the support, without this human contact and someone checking up on you all the time, every participant said it would be quite hard to come off benzos. So to the next slide, which just shows an overview of the points I've discussed. This study is currently unpublished, working towards publication, and it's hoping to support a further project to develop and test an intervention that meets the needs of benzo users. So we're currently awaiting the outcome of a bid for that. To the final slide, I'd just like to thank all the participants who took the time to speak to me and open up about their history of addiction and often mental health issues. And thank you to the services who assisted with recruitment, and thanks to the DRNS Benzo Research Group, especially Katrina and Joe, for helping out, and thanks for listening.
Thanks so much, Harriet. That was great. Thanks for that. A useful overview of users' perspectives in terms of benzo use. If I can now move on to our third speaker, it's Joe McManus. Over to you, Joe. Thanks.
Hi, I'm Jo McManus, and I work for Greater Glasgow and Clyde Health Board as the Health Improvement Lead for Drug Prevention and Harm Reduction. And my presentation is really going to build on some of the themes that have been touched on already. So I'm going to look at some of the realities and the difficulties of encouraging safer use of benzodiazepines amongst people who choose to use them, and some of the challenges that we've come up against producing harm reduction information for this group. Next slide, please. Okay, Andy has already touched on some of the different types of benzos, but I just wanted to illustrate in a bit more detail the confusion and uncertainty of what's out there on the street. On the slide, you can see a small sample of some of the pills that have been available recently. Some of the differences are really small and some are quite obvious. But for people using them, it really is often a lottery. So we often get, oh, it's the speckled ones, it's the ones with the beveled edges, they're green, they're blue, they're pink, they're yellow, they're white, they've got half score, they've got no score, they're powdery, they're bitter. There is so many small but really important differences, but they actually tell you very little. And often people don't have a choice of what they're using anyway. So they may have a feeling that something is a bit dangerous, or they've heard, but if that's all that's available, then the chances are they probably will use it anyway. How do they make a choice if they do have one? Quite often they'll say, oh, it's because they've tried them before, you know, personal experience, but it may not be the same. Even though it looks the same, it might not be from batch to batch. There can be differences. It can be a completely different chemical that's in it. It's it really, there's no quality control. Packaging is also not a foolproof guide. They can come in packages that look like the real deal and they test to be something completely different. So it is a total lottery. On top of all that, different benzodiazepines have different amounts and different concentrations. So some of the new ones that are coming through, the concentration is so low they don't show up on routine tests. So it's really, really difficult for anybody to know what we're dealing with. They have got different half-lives and they've got different onset times. So it's a gamble, and it's a gamble that people can be taking with their lives. Without real-time and regular testing or drug checking, we don't know what's actually circulating. We don't know what strength it is, and we don't know what else is in it, never mind what the main ingredient of it is. What is the current normal dose? It could be 0.8 milligrams, sometimes it could be 1.2, and we don't know what the normal dose is. So how do we tell people that they're taking too much? And how relevant is it when people are taking 5, 10, 20 pills upwards? How relevant is it what, 0.8 mils or 0.9? There's very little and that you can advise people on again. Next slide, please. Okay, so when we speak to people, they say we know the risks, and as Harriet's research showed, more often than not, they think or they do know what the risks are. They've got a good idea what they are. Speaking to different people in different situations highlights this. So we work with A&E and we work with acute liaison. They are often telling us that people are repeat attenders. They're coming in and out on a regular basis with the same effects, the same behaviours linked to their drug use. It doesn't put them off. They also report, they tell us that it's really difficult sometimes working with people because the confusion levels and the levels of intoxication make it very difficult to understand what it is they've actually taken, what their actual problems are. Quite often they're admitted onto the ward and they can be there for a few days and still have no memory, so they've lost 2 or 3 days of their life. And we hear that quite regularly from people, that they are actually losing time. They lose days of their life. They don't know, they're waking up places, they don't know how they've got there or why they've got there. I did some work in prison with some focus groups, and they were genuinely saying, as Harriet touched on, they genuinely didn't remember what the crime. They admit they must have committed some kind of crime, but they didn't remember actually doing it because they were under the influence at the time. When they're in there, they are in, and quite often they are eating properly, they're going to the gym, they're feeling okay, they know they're healthy. But when you talk to them about when they get out on liberation, they know, and they say they'll go back to using benzos again. One of the first things they'll do is go and try and source them. And any realistic opportunities, such as going to the gym, well, I won't have any money because all my money is going to go on using benzos. So even though they know the trouble they've got them into, they know what has the effect they're having on their lives, their families, etc., they go back to it. They go back to the same life, and benzos become their main priority again. Not always just benzos. We also have a city centre living experience group, and we discussed with them quite often what happens around with the drug use and benzos. They're very aware of what happens and what the negative effects of benzos are, and there's full recognition from them about how damaging they are, not just physically, but to their mental health, to their well-being, to their physical health, to their quality of life. But despite all these negative effects, they carry on using them, and they have many, many repeated attempts to stop using them because they know that ideally that might be what they would like, to get a period in their life where they've not got that chaos. However, it proves to be really, really difficult for them. They're also very aware of the dangers of trying to stop suddenly, so seizures, etc. They know that to stop suddenly can cause them real harm. Any help that they get doing these detoxes tends to be from friends, not from services. So somebody that will sit with them and try and make sure that they're safe. But 9 times out of 10, I would say they still return to using them again. So they still choose to go back and use the drugs. And they're cheap, they're there, they're readily available. So the option is still there for them, if it is an option. Next slide, please. So combined risks, the focus I know today is benzodiazepines, and for the purpose of safer use and harm reduction, I think we've still got to acknowledge that there's a number of other factors that impact and contribute to people's decision making and their own personal risk factors. Things like compromised physical health, including respiratory problems, underlying health conditions, poor general health, their mental health, their living in their life circumstances, challenges of day-to-day survival, alongside the easy availability of cheap, potent pills and other drugs that work to change things for them for a short while, take them away from what they're dealing with on a day-to-day basis, even just for a short while. But they know it won't last, and they know it's actually probably just making the problem worse. it is a perfect storm, I would suggest, especially in these circumstances in the climate today. Next slide, please. So, taking into consideration all that I have said, we might as well just take this approach, just hand them over and say, please enjoy responsibly. But it's not an option. So what do we do? What do we try and do? Next slide, please. Okay, so every so often something happens and we get a request for some kind of communication to be developed to raise awareness about the dangers of street benzos. It often follows a cluster of incidents that may or may not be related to particular pills. I say that because without any drug testing or toxicology in real time, we can't be sure. So it has happened in the past that we've jumped to conclusions that it's been related to these particular pills, and that has not proved to be the case. To me, there is inherent dangers in some of that stuff. However, my colleague and I, we have been faced with the task on more than one occasion of trying to produce something for people who use drugs. And each time we sit down and we ask ourselves, what can we say that is going to make people behave differently, to make safer choices and to use pills more safely? Given what I've already said, you may agree it really is not an easy task. Sometimes we think it is really quite impossible. So we're saying you use 5 to 30 pills a day at a time. You use 5 to 30 pills at a time. Take a test dose, a quarter of a pill. How realistic is that for somebody who's chaotically using drugs? Only use a dealer you know. Do the dealers know any better? I would suggest most of them probably don't. We say wait for the tablets to take effect before taking any more. It's really unlikely that they'll do that. And anyway, the effect on short-term memory means that they might not even remember they've taken them. They've all got different onset times. How many have they taken? When have they taken them? It's the chances of them waiting just to see how safe they are is limited. These and several of our other harm reduction messages are not just realistic for this type of drug use, they're just not realistic. We also produce alerts for particular pills, and that might suggest to some people that the other ones out there are less dangerous, but we don't actually know that, so we could just be adding to the overall risk. We have issues with a perfect example recently, the Public Health England issue that came out. They issued an alert over pills. The ones that were mentioned were not ones that we were concerned about at that time. We decided as a drug trend monitoring group, which is the group that I chair, which looks tries to react to drug trends, that we were not going to put this out because it was confusing and those pills were not our major concern. However, it went out through other sources, and I think it just does confuse people because it names pills that are not there. And again, is that a danger that you're maybe suggesting that the ones that are out there are not as dangerous? I think we have to be really careful about what we do and what we say. Next slide, please. Okay, so we can't just leave it at that. We still do need to do something because we do care about people genuinely, and we do want them to be as safe as they can if they choose to use drugs. So in an attempt to produce something a bit more meaningful, we went and spoke to some of our city centre population who use drugs in Glasgow about what we could say that might be more useful for them. And it was really, really helpful, and they were very willing to talk to us and give us a bit of a pointer in directions that we perhaps hadn't thought about going. So they gave us some really practical points that we hadn't thought of. Things like, don't carry large amounts on you, because if you do, you may forget that you've already taken some, so you will take more. Don't use alcohol to help you sleep through withdrawals or fits and seizures, because people were reportedly doing that at night. They knew they would waken up, perhaps having a seizure from not having taken pills for a while, and they were using alcohol to help them. So another depressant, it's making the risk. Polydrug use is our biggest problem. So one of the practical things we could say was, please don't use alcohol to try and control the fits or the withdrawals. So this and some other advice was included into a booklet that we produced, and we sent that out to all workers who engage with people who use benzos. It really helped. It helps them, they say, to have difficult conversations with people about the dangers, not only of benzodiazepines, but of polydrug use. It gets the conversation going, and because it's informed by people who know what they're talking about through experience, people will give it more credibility, or that is our hope. A plea here, if anybody has any better ideas or any ideas about how we can have more meaningful engagement around this, please get in touch. My email address is at the end, because as I say, we quite often are extremely, it's extremely challenging. Next slide, please. This is just to wrap up, really. So in conclusion, although today is about benzos, and I have kind of touched on the benzos and the difficulties that we have, I don't think we can look at it in isolation as just that is the problem, because like most things, it's more complex than that. The pills are definitely cheap, they are available, and they do work. They work for the people who use them. But the real dangers are that from the amount and the numbers of drugs people use, they then have their own dangers. We need to listen more to what people who are living experience are saying. They're the ones who are out there. They are the ones who are using the drugs that are on the street, and they know the choices, they know the difficulties of what is going on. And we need to make sure that we're engaging and offering people what they need to make the changes to their lives, not just about their drug use. We need to be more holistic than that. And that's me. Thanks for listening.
That's great, thanks, Jo. And I'm sure we'll come back to a lot of those issues in the questions that you've raised. If I can now ask our final speaker today, Craig McKenzie. Craig.
Thanks, David. Okay, so thank you very much. So my name is Craig McKenzie, and I'm going to talk to you today. I'm going to split this talk into 3 sections. I'm going to go into a little more depth about the inherent risks of benzodiazepines and street benzodiazepines. It's been touched upon already. I'll just go into a bit more detail. I'll discuss about what is actually out there right now. So these drugs change all the time. So what's actually on the street that we know about just now? And then I'll talk about possible responses as a discussion point. Okay, so next slide, thank you. So I'm a chemist. I analyze drugs. I interpret what I find. And so I just wanted to go into a little bit more detail about the understanding the risk factors just with the drugs themselves, taking into account everything that Jo and the other panelists have said, that this is a part of the problem, but one that I want to really look at in detail. So the actual benzodiazepine present, it changes over time. And we'll talk about that in just a moment, what drugs we're actually seeing. But one of the really important things is the mass of the benzodiazepine present in each tablet, how variable it is, how uniform it is throughout the tablet, and especially if people are taking very large doses. And something else that in a market with no quality control or quality assurance, it's bad enough and troublesome enough and problematic enough to have those tablets containing the benzodiazepines that they do. But what about what we would term as rogue non-benzodiazepine drug tablets, where probably unknown to the supplier, something else is in the bucket that they put into the tablet machine. And then you get drugs with unknown substances, and certainly not what the user would expect. So we'll talk a little bit about that. So just talking about that, here are a couple of tablets. We get lots of these that we analyze in our lab. And so the first one might be expected to be Xanax, but increasingly that's actually containing a drug which is more potent and is becoming more prevalent. So a drug called flualprazolam. The next one is is quite a common kind of MSJ blue tablet. A user might expect that to contain diazepam or atizolam, but it actually contains alprazolam. And this is really quite common in terms of not changing in concentration and the actual drug present. And the issue here is that if you've got mixtures of drugs from different batches, you're taking lots and lots at the same time. If those drugs have different onset times, they have different half-lives, and we'll discuss that, then you've got some real problems. And of course, with polydrug use, if a user has taken crack cocaine or a large amount of cocaine and they're trying to take what they think are diazepam to come back off of it, but they're actually taking very, very strong flualprazolam, then you will have particular issues around polydrug use. And of course, everyone who takes them is different. They have their own health conditions, own health status, and there's natural variation between people. Next slide, please. Apologies for the chemical structures, but I put this up for a reason. These are the drugs, these are the different benzodiazepine drugs that have been reported to the European Union early warning system. So there are a lot of benzodiazepines out there. So the question is, which benzodiazepines have appeared and which ones will appear, and what's the difference between them? So if you can see them, it's quite small. The ones in green, a full green line, did have quite an impact on the drug market. I've circled atizolam, I've put it in red because that really has taken a hold and is now the most prevalent drug on the market. But why? Why was that? And then in the blue dashed lines, we've got drugs which have appeared, but they haven't really yet taken a hold in any way. And then I put a green box around flualprazolam, which is a drug of real concern. It's still not seen anywhere near as the atizolam and diazepam, but it's something we're keeping a really close eye on. So what's the reason why one drug takes hold over the other? Why that drug and why at the point that it does? Next slide, please. Apologies for the figures, but I just wanted to go into a little bit more depth around what we were talking about of the inherent risk. Benzodiazepines, the drug itself, are all not the same. So testing is a really important thing to do in order to understand risk, as Joe said. But of course, when the tablet content is very variable and tablets look the same, contain different things, how do you communicate risk? So some of this data is estimated, some of it is from user forums. But here, if I say that Valium or diazepam has a relative potency of 1, then Andy's already mentioned that atizolam might have around 5 or 10 times the strength. Then you've got alprazolam, which is stronger. And then you've got the ones I've put in bold here, flualprazolam and flubramazolam, which are particularly concerning because user fora, what we know about their pharmacology, tells us that those drugs are really, really potent benzodiazepines. So if you're taking those in a tablet, and the tablet contains the same amount of that drug as it did atizolam, then you have a problem. You have a problem anyway, but you're layering this extra problem. So you're putting very potent drugs into the market without being able to tell that they're there. It's not a simple thing to say what's equivalent, but I've just put there on the side that maybe a 10 milligram diazepam tablet might have around about the same kind of general potency as a 1 to 2 milligram atizolam tablet, but of course they'll act differently in the body, so it's not just about the potency. And if I've got alprazolam, I might hope that there was less per tablet, and certainly if I had flualprazolam and flubramazolam, I might expect that there's a really, really tiny amount in that tablet. If you're making those tablets, controlling that becomes really, really difficult. So there is an inherent risk that you'll get batches of low concentration, but still high enough to cause real harm. Next slide, please. So the second part is, I'm very grateful to my colleagues across Scotland. I'm involved in drug testing in prisons, non-judicial drug testing for intelligence. And I spoke to all my colleagues across Scotland who are involved in drug testing. And normally those people are involved in drug testing for the criminal justice system. So here's the latest data on what we're seeing in the market from the forensic services, forensic laboratory. And what we're seeing still is that atizolam remains the primary benzodiazepine on the market. It's seized and seen in much higher levels on the street market than diazepam. But now you're seeing flualprazolam coming up and being more prevalent. It's still a lot less than atizolam, but flualprazolam, if you remember, is one of particular concern because of its potency and perceived strength. And then we saw alprazolam, better known as Xanax. So that we're seeing some issues around Xanax bars, in particular, containing flualprazolam instead of Xanax, and flualprazolam is stronger. And then you detect those other drugs. Flubramazolam, the one I mentioned, was allegedly, from the information that we have, and it's very scarce, may be particularly strong, is also being detected, but in really small numbers. Next slide, please. So in prisons where I do a lot of drug testing, we see the same things, and I'll add to this slide now. So we see relatively low numbers because that wasn't originally our focus, but now it is. And we see the same drugs, atizolam, diazepam, alprazolam, and I would like to add flualprazolam to that. It's becoming increasingly common that we're detecting. And in prisons, you've got a lot of concealment, and therefore that can add to the danger of the drug taking. So you get these crushed powders, which may or not have been as a result of concealment of the drug. Well, at least when I had a tablet, I kind of had some idea of what dose to take. But if I've got that powder, I have literally no idea. Is that just the bulking agent? Is it just food dye? How much drug is actually present? So you've increased the risk. Next slide, please. So in terms of what is being seen in post-mortem toxicology, I'd like to thank my colleagues at the University of Glasgow very much, and NHS Grampian for the information. And this was really just, what are you seeing? And in the University of Glasgow cases, which are probably 80 to 90% of the post-mortem toxicology cases in Scotland are being handled by, then you're seeing, again, atizolam being seen a lot more, diazepam next, and then you're seeing this range of drugs. And what you're seeing here is you're seeing more common just mixtures of benzodiazepines in the same toxicology samples, rather than atizolam plus everything else. You're now seeing atizolam plus other benzodiazepines plus everything else. There are also indications of some localized variation. So if you look at the Aberdeen area, the northeast of Scotland, then diazepam is the most common detected drug. And in 2019, there was a particular issue with alprazolam. Now in 2020, we're seeing atizolam taking alprazolam's place, and we're also seeing low numbers, but increasing numbers of things like flualprazolam and flupramazolam, those particular strong drugs. And we see something similar in criminal toxicology. So in criminal cases where toxicology is requested, you see atizolam and diazepam around about the same because it's a different population you may be looking at. But you're also seeing low detections of other drugs. And I would add another drug, flubromazepam, to that list that's given at the bottom. Next slide, please. If you look at the wider market, so Wedanos are an organization that users can send their drugs to be tested anonymously into the service, and they're obviously looking at a much wider UK market. So what's going on in their testing? And this is data is publicly available, and I just pulled it together for the last 2 years up until just a couple of weeks ago. And if you look at the last bar chart, you see that diazepam and atizolam are there, but you're also seeing what looks like apparently increasing proportions in their testing, and it is a different market. I would stress that. It's not, there will be street benzodiazepines in here, but there's also other markets like purchasing online and online vendors, and there'll be different markets. But you're seeing the same patterns. Flubramazolam increasing apparently in proportions of tested samples, and flualprazolam increasing. It's hard to link that to a Scottish street benzo market, but it is telling us some interesting things and some similar things. And we're seeing the same things on international markets. Next slide, please. So just in summary for the data snapshot, atizolam remains the primary benzodiazepine, is by far the most common in casework. There are some regional differences. There's increased prevalence, but it's still, in comparison to atizolam, a lower proportion of some of those benzodiazepines, and I call them of specific concern. And then it's to really keep a close watch on that and look out for any particular flashpoints or effects. And our data reflects national and international markets. Next slide, please. So these are just thoughts to maybe for the discussion. So what drives the market? You know, we've already talked about there's different markets, but in Scotland there's a very particular market for street benzodiazepine use. It's obviously perceived to be highly profitable by organised crime gangs. There's high demand for it. And one of the most important things is, where do you actually buy the drug itself? The tablets can be made locally in the UK and Scotland, but where are you buying the actual active ingredients? So how does international legislation affect the availability? And if something changes in the international legislation, will it affect what we will see in Scotland? So we've got the UK legislation. Now, Islam's been controlled since 2017. Flu alprazolam has just been controlled, or is about to be controlled in 2020. And then a major issue is that Islam and flu alprazolam, which have an impact on the Scottish market, are just coming under international control. So will they be available to buy on an international market, or will we see a shift? Or are the supply chains so secure, so well organized, that whether they're controlled internationally or not will not make any difference? But these could be drivers for future change. Next slide, please. So just some discussion points with what we've talked about, we've all talked about today. I'm an analytical chemist, but is more testing required? And that's a debate we can have, because if it is, it needs to be focused and it needs to have a real goal of what it's trying to achieve and be really targeted. At the moment, we see that one of the major issues is the drug type, but it's also about how variable the mass is. And one thing we're not that clear on is what mass per tablet is, what's normal, as Joe said, and what's not normal, so how do you advise? So if you're going to do that testing, it needs to be systematic. You need to really focus on the market, and it needs to be done in real time, not in 2 years after the tablets were seized. It has to be part of a package. If you do additional testing, it won't help you necessarily just on its own. And so if you do testing, you just need to do parallel public health focused testing, and it needs to be parallel to the criminal justice toxicology, and everyone needs to share information as we are already. And we need to maybe have rapid targeted user-facing responses when we get really obvious clusters of non-fatal and or fatal overdoses in particular areas. Identify quickly what is there a particular tablet, as Joe said, there are inherent risks with that, but we need to start thinking about that. And then there's the issue of public-facing services, so which is set up, which the public can engage with, for example, the Webinar service and drug checking services. And I'm just raising those as issues for discussion. Thank you very much. Next slide. So just to say thanks to everyone who put data in. It's not all my data. I'm representing a lot of organizations here who provided me with information. So thank you very much to them. And then just the final slide is just my details if people want to get in touch. Thank you very much for your time.
That's great. Thank you very much, Craig, and that's brought us right up to date. If I can ask all the speakers now to come back, and thanks to all of them for giving a good range of presentations on the current position. And I'm also joined now by my colleague, Austin Smith, who's been looking at all of the questions. So, Austin, we've got 15 minutes left, so hopefully we've got enough questions from our 500 odd participants to fill the 15 minutes.
Yeah, well, therein lies the problem. Trying to summarise, there's quite a lot of interestingly very specific and a yes/no questions, which maybe reflects a need for a sort of wider education around benzos and a wider discussion that maybe we can't hold here. One of the things that came up and people have asked about is about how we got ourselves into this position. Why do we have such a problem in Scotland? What are the characteristics of that problem. And I suppose, you know, some of those questions then suggesting ways out of it, but that's maybe a subject for next week.
Okay, and Andrew, do you want to go first?
So to address the question about how we got ourselves in this position in the first place, well, I think there's no single answer to that. I think drug use in Scotland and drug-related harm in Scotland is complicated by many situations. You can go all the way back to the onset of our problem drug user cohort back in the 1980s and the socioeconomic upheaval that's been attributed to driving that at the time. So there's much bigger, wider macroeconomic factors that we have to acknowledge. If we move specifically to benzodiazepines, though, it's clear from the data that there has been a significant shift in how we deal with benzodiazepines in Scotland since about 2010. Now, there was a change in prescribing practice from that point onwards, and it was very well intentioned because there was concern around about that period about the role of benzodiazepines in drug-related deaths at the time. But that was back in the days where our numbers were much more, I mean, they were perceived to be problematic at the time, but they were much more modest than what we're dealing with now. They were around 500 per annum, which is unacceptably high, but now we're well over 1,000. So the tighter controls in prescribing do appear to have had a role in shifting the street market from one that was mainly dominated with diverted prescriptions to one that is now dominated by these kind of new or novel benzodiazepines. And unfortunately, it seems to be coincidentally at that time, that was when the NPS type drugs really came to the fore, whether it was the stimulant type drugs, the cathinones that we know, but also the benzodiazepine type drugs. And you can trace, as Craig showed in his slide, you can trace the identification of the newer novel benzos on the continent, a lag period of a couple of years, and then they appeared in Scotland. The thing that's interesting, and obviously that increases the risk environment because you know these drugs they lack quality control. I think the thing that's interesting over the last couple of years is previously when we identified these risky drugs like phenazepam, for example, they were put on the banned list and they quickly disappeared. The thing about atizolam is atizolam has been controlled for a couple of years and it hasn't disappeared. It is sustained, and in fact it's accelerated its role in drug-related mortality in Scotland. So there's something particular about that drug and perhaps other drugs now. Either the market has become more sensible and wise to what it needs to do, but these drugs have really outrun the legislation. And maybe, as Craig says, the international legislation might be what's required to interrupt the supply chain. But Craig's slide perfectly articulated, you can only control benzos so much. There's a whole sea of benzos waiting to take their place. So we need to think beyond the drug and think much bigger.
Thanks, Andy. Joe.
Yeah, I agree with everything Andy said, and it is a very complex problem with lots of things that impact on it. I do think it quite often comes down to they are cheap, they are available, and they work for the reasons that people are taking them. They can be produced locally, so you don't have this quite often, you don't have the same issues bringing them into the country. They are depressants which are popular with our drug using communities. And I think it's interesting that elsewhere in Europe, they don't have the same issues with the quantities that people take. So I think all that together just makes it very difficult for us to be able to tackle it, and why we've got this problem specifically with benzodiazepines is anybody's guess, really, as far as I'm concerned.
Okay, thanks. Craig or Harriet, do you want to come in on that, or we'll move to the next question?
Yeah, just to echo that, I think just the normalisation of taking benzos, or how easy it is to take them as well. So I was speaking to a participant who said he could just take them in any social situation. So if he was having a coffee with his friends, if he was out with his family at the pub just before he was going to the gym, it's not seen as problematic, as to say, compared to other drugs, because you can mask it alongside everyday life. So I think it can just go under the cusp quite easily, really.
Thanks. Craig, you want to?
I'm happy to go on to.
Yep. Okay, that's great. Austin, back to you.
And several people asking about an antidote, the treatment that's available to people in accident emergency or in hospital settings. Why isn't that out in the community like naloxone?
I think that's to you, Andrew. You mentioned that, didn't you, in your slides?
Yeah, I'll probably defer to the chemist on this one, but my understanding of flumazenil is it's not as safe a drug as naloxone. Naloxone is one of the safest drugs on the market. Even if you administer it to somebody with no opioids in their system, it's not going to have any effect on them. Whereas flumazenil, I understand, is much more likely to induce seizure if not used by a trained clinical professional. But Craig can probably qualify that.
Well, I actually won't, because it's not my area of expertise. I can analyze them. But yeah, I mean, there are always inherent risks, as you say, with any treatment. It is not a like for like. I understand the sentiment, very, very much so. And it seems an obvious question. But if you consider the sheer amount of drug that we're talking about being used as well, and the different drugs and the different effects and the different onset, that can cause some, you need to really research that very, very carefully in the context that users are experiencing the overdose or the drug use. And that's what I would say there. Needs to be really carefully looked.
Yep. So that's not a straightforward solution there, Elston. And
a lot of questions, I would say, about the prospect of or the potential for drug testing. I'm sort of two camps in that. Is this not the answer in such a complicated drug market? And the other question being whether the people who are most likely to have serious problems in terms of harms and potential overdose deaths, are they a group of people who will use drug testing, and would it be a benefit to that group?
Joe, can I ask you to kick off with that one?
Yeah, I would suggest they would use it. They do want to look after themselves. We have cases frequently where people have presented at services and said they've had a bad experience with something, or they know people in their peer group who have a bad experience, and they would be able to bring a tablet in if they can. And would we test it for them through services? We can't do that, we can't offer it, but it's not because people don't want it. I think there's a kind of fallacy out there that people won't give away their drugs, and maybe there's other drugs they perhaps wouldn't, but with these particular ones, they are very easily got and they are very cheap. So to give somebody a part of a pill is not going to take away much from the drug using experience. So I don't think there's any.
Joe, can I just ask on that particularly? Have you thought about Wedanos? I know that wouldn't be.
We do say to people that they can. They don't want to know. They wouldn't go and do that themselves. You know, they would like to hand the tablet over to you, but they're not going to go through the process of putting it in a bag and sending it away and checking results, etc. So it's not as easy for them to do it that way. If they were able to go in somewhere and have their drugs tested, I think it would be something that they would use as long as it was somewhere that was accessible to them. They don't like travelling far out with their own areas or their routines. And I think also the drug testing would be, they know that it would be of great benefit to them. So I don't see barriers in that at all.
Craig, do you want to add to that as you mentioned it?
Yeah, thank you. I'd like to come in here. I mean, there are different types of drug testing and different types of drug checking, and they have different purposes. So I don't think there's any one single solution. If you're going to take a public health approach, then you have different options, and different the user groups need to be involved in that, the setup of that system as well. Otherwise, they won't engage. It's exactly as Joe said, the choice of engaging or not, or the choice of using a service like Wedanos or not. So we need to understand those. So they need to be part of the conversation. But I would say that for public health drug testing, you might have two back of house type situations where you're gathering intelligence monitoring of what's normal. so that when you see something that isn't normal, you know that it's not normal. So that's one part of it. And then you've got the second part of that is a rapid response. I'm in a city, I suddenly see a spate of 30 or 40 non-fatal overdoses. How do we deal with that? How do we respond to that quickly? And how do we get a targeted message back out to the people who really need to know that? It's not necessarily a general response to everyone. It's a targeted response to the people who need to just say, we know this has got something strange in it. Can you just avoid it? And if you do that, people want it checked. And then you've got the drug checking, which is public facing, which is someone coming in with a drug and having it checked. And that is a really useful thing to do in certain situations, but we have to be really careful about the benzo situation. It's not the same necessarily as looking for 200 milligrams or 300 milligrams of MDMA in an ecstasy tablet. So there are challenges, but I'm sure those challenges can be dealt with, but it's not the same type of testing. It's much more challenging to look for 0.5 milligrams of vatizolam or flupramazole in a 150 milligram tablet. It's a different thing, so we have to think about it differently as well.
Thanks very much. Austin, I think we're rapidly running out of time, I'm afraid, but one last question, maybe not that everyone can answer this one, I guess. But.
Well, maybe everybody wouldn't want to answer this question. I'd summarise this question by saying it's post-mortem toxicology an art or a science. There's questions as to the difference between being implicated in a fatality and being present in toxicology, and whether this is reported differently now than it was previously.
Okay, can I volunteer to answer that one rather than pick on someone? Andy?
Well, I'm not a toxicologist, but I've worked with toxicologists in Scotland for a long time, and I would say that our toxicology is amongst the best in the world. So when our toxicologists tell you that a benzodiazepine was involved in a drug-related death, you can be sure it was involved in a drug-related death. The toxicology standards have been toxicology reporting, particularly for benzodiazepines, has been standardised since 2008. There was a specific pathology subgroup that looked at this through the National Drug-Related Death Forum. So from 2008 onwards, the data is particularly reliable, and that's why it's reported in two different ways. You get the involvement of benzodiazepines or any drug in drug-related death which tells you it contributed to the cause of death, and then you get all the drugs reported. So that was the suite of drugs that were reported in toxicology. So you can pick and choose which of those indicators you want to answer your question.
Craig, do you want to add to that?
No, that's a very. I would echo the comments about the quality of the toxicology testing in Scotland and the standards that are set in that testing. I would just echo that completely.
Yeah. And I guess I'm not sure whether the behind that question was a suggestion that we've actually overplayed it slightly in terms of, but I don't think that's the case. That we've got a massive issue that we need to address. Absolutely. Okay, we're going to have to wind up there, I'm afraid. But thanks everyone for their contributions today, and it really does set us up really nicely for the session a week today, which is looking more specifically at treatment and prescribing issues. And I'm sure we'll come back to some of those issues around testing and other things we've explored today. This session will be, or has been recorded rather, and will be up on our YouTube channel as soon as possible. We will be sending out an evaluation shortly, and it would be very helpful if you could complete that. So the next session, as I said, is Scottish Drugs Forum with the Drug Death Taskforce. Will be this time next week on the 9th of October, and I say looking at more closely around treatment and prescribing issues. Links to register for the webinar will be included on the evaluation email that will be sent out to you. And finally, I would like to thank you all for attending, and a special thanks to today's speakers for what you agree, I think, has been a really interesting and informative session, and sets the ground for, say, next week's session. Thanks again, and goodbye for now. Thank you.
Thank you.
Thanks, everyone.
Thank you. Yeah.